later, and I will make sure that they are. However, okay, just because don't wait on me, right? I will make sure that they are the correct ones. It could be totally my bad, and I apologize for that. But if we are talking about something like infective endocarditis or pericarditis or cardiac tamponade, the index works really good to be able to find out where that is in your book. Okay, so don't, and I'm not saying that to try to be funny, but I really am just saying that you have this information at your fingertips. Utilize that cardiac subject guide and have that open and say, oh, okay, I need to know about pericarditis, and then go to the book and see where it's at, okay? And if you don't need to, you have all the information you need, then that's fine, don't use the book, okay? But I encourage you guys, this is the section where you're going to probably need to open it, okay? Does that make sense? I apologize, I'll look into that though, okay? That very well could be my bad. But do me a favor and make sure you guys have the 15th edition.
It is the 15th, I just looked at it, but yeah.
They're still off? Okay, I will double check that. Okay, so let's do this first one, okay? Patient presentation. This happens, guys. Remember, you are the detectives. You will be having these patients and you are going to be getting a report, okay? We don't have time to practice this week. We will practice again next week. So I really want you guys to start developing that skill about being able to take a report. So pretend like you're taking a report here. But this is what will happen is you will come, you will get a report, and you'll be like, what is going on with my patient, okay? What kinds of things do I want to accomplish today? What kinds of things do I want to advocate and be proactive about talking to the physician about, okay? So we have a 35-year-old male presents to the ED with fever of 41 degrees Celsius. Patient is a reported IV drug abuser. Patient is noted to have petechiae on his trunk and arms. Upon auscultation, the patient has a significant heart murmur, okay? Patient complains of fingers and toes being painful. It's kind of a weird symptom, right? Upon further inspection, nodules are found to be palpated on his fingers and toes. Okay, we got some vital signs. Heart rate, 121, high, low, or normal? High, okay, great. Respirators of 32, high, low, or normal? Perfect. Blood pressure, 90/45, MAP of 60. Okay, low, perfect. Okay, so in a MAP of 60, what are we worried about? Perfect, end organ perfusion, right? Excellent, okay. Temp 41 degrees Celsius, high, low, or normal? It's high, okay, so we think that this patient has a fever, right? And then O2 sat 91% on room air, okay? So right off the gate, right, let's look at the vitals, for example. So we know he has a fever. Can you attribute some of his vital signs to being febrile? Okay, which ones?
Tacky.
Okay, so he's tacky. His heart rate's elevated. What else? Possibly low blood pressure. Okay, I like it. What else? Respirators, right? Absolutely. Okay, perfect. And then what about that SAT? Do you think that a 35-year-old should be satting 91% on room air? No. Okay? Unless he was unflagged, right, at like, what is flag, like 7,000, 8,000 feet, right? Maybe it could be a little bit lower, but 91 is pretty low, right? It's not necessarily me wanting to put on O2 as an intervention, but I'm certainly keeping an eye on that, right? Because it's not what one would expect from a 35-year-old, okay? Now, let's look at some of the history. What stands out to you in terms of the history?
IV drug user.
IV drug abuser. Okay, so that should be doing some sort of bells in your head, okay? Remember, history matters. We're all detectives here, okay? You guys are going to all watch Law and Order by the end of your session with me. You're going to love it, okay? I mean, it really does make you, like, appreciate your life. I'm not lying, okay? And then what other things that stand out?
The petechiae.
Okay, so petechiae. Does everyone know what petechiae is? Okay, so it kind of looks like little dots, like little under the skin hemorrhages, okay, tiny, okay? And he has that on his trunk and his arms bilaterally, okay? And then we have a significant heart murmur, okay? So when I mean significant, that means that I put my stethoscope on his chest and I can hear. Who's good at auscultating murmurs here? Okay, no shade, guys. Okay, I've been ICU nurse for 15 years. Murmurs are hard. Oftentimes, I hear something and I'm like, that doesn't sound normal. Can I diagnose what it is? Probably not, but I know that something's abnormal, right? I'm not hearing that S1, S2 loved up. There's something extra about it, okay? Kevin, however, who watched his lecture, by the way? Be honest, okay? Isn't he great, right? Explains things really, really well. If you haven't, I highly recommend that you do. You listen to that lecture, okay? He's like an expert, of course he is, at murmurs, right? You can always diagnose them, blah, 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 right? So, again, when we auscultate something, we hear something different. Something's abnormal, okay? So, given this patient's presentation, what do we think is happening, okay? What do you think is going on? And then, right, how can you confirm this diagnosis? So take a couple minutes, it's a two for kind of question, and let's answer this.
Infective endocarditis.
Infective.
Maybe.
It's called infective. I've been calling it ineffective recently.
You guys can actually discuss it. I love it. Okay, nurses and team support. Take a moment with your team and think about what we're dealing with here, okay? And then how are you going to confirm it?
And she bolded in large. She added bold letters for IE is fever and fast heartbeat. No. She said that usually those are the two hallmark symptoms or something like that. I think definitely fever was one. Maybe
And for pain, they can do it like this position, almost like COPD.
to relief or
Yeah. See, no?
Yeah, and how can you got that?
That's 8. You guys need to get some glasses. When you get better glasses.
Two people? Only two people know what this is? This is where it behooves you, right? I know, third week, you guys are tired. You already are tired. You got things going on, cardiac's a lot, right? You've heard things about my tests, either good or bad. This is where you need to buckle down, okay? From here on out, it's intense, okay? So this is where in another window, you have either your soft track open or your book. That way you can look at what is going on, okay?
Infective endocarditis was in module 3 or module 2?
3.
3? ¿Qué tienes, Valeria? ¿Estás enferma?
Tengo gripa.
Oh,
Ya. Me hice un test, pero todo negativo. Dije, tengo que esperar.
¿Te pusiste la vacuna o no te la pusiste?
Yeah?
Do you usually get sick from it?
From the, no, because I got it like a month ago.
Making things
So I think it's
hard.
like other type of virus.
Yeah,
We know like
I know that one is going around.
Okay, so we have some things up here, right? We have
No change
infectoendocarditis.
Oh.
I love
No
it.
change
Okay. And then we have some things about diagnosis, right? So let's talk about infective endocarditis for just a quick second. Okay, do you guys know a little bit about the pathophysiology behind infective endocarditis? Anybody read that, mention that, right? So a couple things, right? If you think about where it's at in the heart, right? There's 3 different layers to the heart, okay? There's the endocardium, okay? Myocardium, and then the pericardial sac, and the pericardium, okay? So we are talking about, right, make it make sense. Endocarditis, okay? And then we have a clue, it says infective. Infective endocarditis, right? So the innermost lining of the heart, okay? Carditis, itis is what? Inflammation, okay? So the innermost layer of the heart, there's some inflammation going on, okay? Where that is in the heart, oftentimes that has to do with the valves, okay? The innermost lining of the heart is the valves. That's what we're talking about. That's the problem here, okay? So what are some risk factors really quick to infective endocarditis?
IV drug.
Okay, perfect. IV drug user. Okay, what else? Sepsis. Okay, what else?
Patients with prosthetic valves.
Excellent. Yep, patient with prosthetic valves. So something has already been worked on there, right? Whether it's replacement or mechanical valve, right? Biological valves or a mechanical valve, okay? And then my personal fear, right?
The infection from the mouth as well?
Yes, dental, okay? I mean, recently I went and I had a deep cleaning, you guys, and the hygienist probably thought I was a freak, okay? So first of all, she's taking my vitals before this, and I was like, I've never had my vitals taken before this. What are you doing, right? And then we go through this whole process of deep cleaning, and she's like, okay, you're good. And I was like, wait, I think I need antibiotics. And she's like, why do you think that? I was like, I don't want to get endocarditis. And she's like, no, you're gonna be fine. I was like, you know what? I'm gonna need to talk to someone above you. Like, who is the dentist available? I gotta talk to him. I got reassurance, right? Because again, this happens. We just had a patient on ECMO who had endocarditis, significant endocarditis. He was young. He was like in his 30s, and he had a recurrent bout, and then his heart essentially just, it's called like the stone heart, or just didn't work anymore, and he had to go on ECMO because of his oral dental procedures and then lack thereof dentition, okay? So it happens. Everybody's gonna make their dentist appointments today. I just know it, okay? So again, a lot of risk factors. Someone being on HD, right? How many patients in the hospital have renal failure that are on HD? Quite a lot, actually, okay? So HD, body piercings can put someone at risk. Someone that's, I know, right? That's a surprise, okay? Being immunocompromised can put someone at risk for an infective carditis. So again, right, we talked about in our patient scenario, the IV drug abuser, right? So again, that should have been a clue to you as to what we were talking about, okay? So what ends up happening, right? And so why I talk about this is because sometimes when you talk about the pathophysiology, it helps you to understand what kind of treatment, nursing interventions you're gonna have to do, okay? So in the valve, right? How many valves are in the heart? 4. What are they called? Okay, so right side of the heart, what are the 2 valves? Tricuspid and pulmonary, right? Left side of the heart, what are the 2 valves? Mitral and aortic. Okay, perfect, excellent. Oftentimes the left side, because it's the higher pressure side, has more issues, okay? More turbulence, more problems, okay? It's not to say that there's not tricuspid or pulmonary problems people can have, okay? But oftentimes it's those mitral and aortic valves that we're talking about, okay? So, in talking about the pathophysiology, right, this is what happens. There's some sort of either deformity or injury to that valve, okay? There's a clot that forms. Then there's microorganisms, right? Infectious microorganisms, those germs that we don't want, right? Person hasn't seen the dentist in a long time and the germs are like flourishing in the mouth and then they just travel to the heart. I don't know why your mouth is connected to your heart, but it sure is, okay? That's why I always want antibiotics. I'm that weirdo, okay? When I go to the dentist. And so then what happens is that there's vegetations that form on those valves, okay? And then more clot, because there's this constant inflammation kind of process happening, okay? And so this is how I think of it, an airstream. Does anybody, do you guys, have you seen these on like the road? Does anybody have one?
Oh, yeah.
They're very expensive actually, okay? Because they last forever, okay? Forever. So you can see here, right, that it's like a metal kind of tube looking thing, right? So when I think of vegetations, this is what I think of, okay? This is what I think of. Now, Professor Blair, what are you talking about? You wanna go camping? Well, of course, I always wanna go camping, okay? But why are you talking about these weird trailers? Why does this matter, right? I need you in your brain to be thinking about that the vegetations on these people's valves are like these airstreams, almost impenetrable, okay? Almost impenetrable. And why that's important is because it's going to impact the kind of treatment that you will have to be providing to your patient, okay? You can't just give a 5-day course, a 3-day course of antibiotics to these people, okay? It's going to have to be longer term because they're like this. The vegetations are like this. Coupled with the fact that, do you think that if you got into an accident, wouldn't that do some damage? You probably wouldn't want to be the Honda Civic that ran into that, right? You'd probably like go underneath it like a semi, because it's made out of metal, right? So when you're thinking of vegetations, I know you're gonna be like, wow, Professor Bloor is so weird, but I'm weird in a good way, okay? I want you to be thinking of, oh my gosh, it's gonna do that every time, that's annoying. I want you to be thinking of the Airstream, okay? Does that make sense? Okay, so now, how can you confirm the diagnosis? We got some things here, okay? So, an echocardiogram, what is that going to do? What the heck is an echocardiogram?
Ultrasound of the
It's an ultrasound, excellent, okay. There's 2 types of echocardiogram that your patient can get, okay? There's a non-invasive and an invasive, okay? The transthoracic echocardiogram is the non-invasive one. That's literally where they put a probe on the patient's heart, like outside of it, right? And just scan it, okay? That's non-invasive. Now, the invasive one is the transesophageal echocardiogram, TEE. So we have, don't get confused, you got this, okay? It's early, drink your coffee. TTE, right? Transthoracic echocardiogram. That's the non-invasive one. And then the TEE is the transesophageal echocardiogram, where they take a scope and they put it down into the esophagus and they get a picture like right behind the heart, okay? Now, which one's more invasive?
TEE.
TEE, excellent, okay, perfect, okay. Do you think that you're gonna need to get consent to have that kind of a procedure?
Yes.
Absolutely, okay. Do you think that you might need to do a little conscious sedation for that? Do you think someone, like, do you guys want a probe down into your esophagus right now? Probably gonna throw up, right? I mean, that's what I think, okay? Years ago, I let students put an NG tube in. Worst idea I've ever had in my life. Worst idea, okay? Whatever I had for lunch just came right back up, okay? It wasn't great.
Fortunately, you had a tube in your throat, so.
Yeah, I mean, right? It did get clogged up by the salad and the other particles, but you know, hey, whatever. Timing was not of essence. So in this kind of situation, when we have an invasive procedure like this, right, you might need to give some conscious sedation. So a little in review, right, let's insert it. What kinds of drugs might you anticipate giving? Versed, I love it. Tiny little bit of Versed. What else? What else do you think? Do you want to, like, pain medicine? Okay, I love it. That sounds great. So pre-medicate with like an antiemetic. Name one. Zofran. I love it. That sounds great. I wish I would have gotten Zofran. Good thinking. What about pain though? What about pain? Do you want to maybe, do you think that it might be uncomfortable to stick something down someone's throat?
Yes.
So what kind of pain medicine would you maybe want to give them? Fentanyl? Okay, perfect. Usually, when we're talking about conscious sedation, the duo, the best friends that you have is Versed and fentanyl, okay? Shoot, I just, got the order from the physician, and this patient's an 87-year-old, not this patient, a different patient that we're doing TEE on, and gosh, I pushed 5 of Versed and 50 of fentanyl, and she's looking real sleepy, / maybe abdominal breathing, yikes. What do you think I should maybe possibly call the doctor and then anticipate giving? Narcan, okay, that's gonna take care of what? The fentanyl, okay, that's the reversal for the fentanyl. What is the reversal for the midazolam? Romaziclam? Yeah, flumazenol? Yeah, perfect, 2 different names, yeah, absolutely, okay, so again, be aware, if you're giving drugs, do you have a reversal, especially when it comes to, what is it called? I don't know why this is not hiding your names. Okay, perfect. So TE versus TEE, that is the first thing that we can use to diagnose, okay, absolutely. The second thing that we would use is blood cultures, okay? How many sets do you think you want?
2 to 3 sets.
2 to 3 sets, at least 2. I'd love 3, but absolutely, okay? And so you have a resident. Remember, it's July. No shade, but that's when they all start. The new doctors, they're very excited to be new doctors, much like you guys are gonna be very excited to be new nurses. And they come in and they're like, hey, this guy is infectious, okay? He has a fever, right? His white counts through the roof. I'm gonna start antibiotics. And you're like, oh, okay, yeah, that sounds great, okay. Do you wanna get the give the antibiotics before or after you get the blood cultures? Antibiotics after cultures, absolutely. Okay, super, super important. This is when you might have to call lab and say, hey, I have these antibiotics, I need them to be timely. Can you send someone up to draw blood cultures? Okay, super important. Okay, so again, if you think about the pathophysiology, right? If you think about the pathophysiology of those air streams, right? We want something to visualize, to see the vegetations on the valves. Maybe it's on just one valve, maybe it's on 2, maybe it's on all 4. That sounds terrible and horrible, okay? And then you want to get the blood cultures. Why are we getting blood cultures? Why do you think that's important in this particular situation?
So we can know what antibiotic works best.
Yes, absolutely. So you may, okay, blood cultures take a little bit to cook, okay? It takes a little bit for that organism to grow out. So you could anticipate starting what is called broad spectrum antibiotics, right? Broad spectrum meaning it covers a wide host of things, okay? But again, think about the airstream, right? That crazy picture that I made you look at, right? Everybody's gonna go out and buy one because you all wanna be camping aficionados like me, right? They're very expensive though. You need to understand that the broad spectrum antibiotics are not gonna do it, okay? The broad spectrum antibiotics are not gonna do it. You are going to need a specific type that is geared toward that specific organism. So that is why blood cultures are so important, okay? Does that make sense?
Yes.
Okay, perfect. Questions about this? No? Okay. Okay, so what treatment do you anticipate? What nursing interventions can you expect, and then what teaching should be included? Okay. Now remember, every sort of disease process has complications that go with it. Okay? So when thinking of infective endocarditis, thinking of those vegetations, right? Vegetations that are filled with microorganisms, clots, right? It's this huge kind of clot, bacterial, airstream looking thing. Be thinking about what kinds of complications do I need to be on the lookout for with my patient, okay? So take a couple minutes, write up your answers. I'm probably gonna have to hide your names every single time. I don't know why I have to do that, but it's fine.
We can see them on our end anyway, even when we have to.
Really? All right, well everyone just, you gotta like pick a different name, I guess, or like a code name. Sorry guys, I don't know why it's not hiding it.
Stop using drugs.
So remember, this is what you're up against, okay? You guys, you're gonna walk away from my house and be like, man, she is so weird. I totally forgot, super shout out to Scarlett for taking all that time for that video. I know that that was rough, I'm so sorry. But everyone appreciates it, absolutely. So, good job. I forgot to email you, I apologize. Okay, so let's talk about the nursing interventions first, okay? Actually, let's do the treatment first, that's more fun, okay? So if you had to penetrate, right, if you had to get rid of something that looks like this fabulous Airstream, you would think, we already kind of talked about this, specific antibiotics, right? Again, is this the type that you are going to be taking for 5 to 7 days? Absolutely not, okay? Absolutely not. These most definitely are going to be IV, okay? IV is always more potent than PO, okay? Why? Why do you think IV is more potent than PO?
Because it goes directly through the bloodstream.
It goes into the bloodstream, right? It doesn't need to go into your stomach and have to be broken down with all those
And the
enzymes and everything.
half-life too.
What'd you say?
The half-life for PO.
Absolutely, totally. There's lots of factors. IV is always king, okay? IV is always king. That's why when we get to sepsis, you will never have someone that's on sepsis that's getting PO antibiotics, ever. Okay, they're always going to be IV. IV is king, okay? Now, we talked about that we need a long-term antibiotic situation. Oh, I love it, it's right here, okay? Usually, it's at 4 to 6 weeks. Usually, it's like that, 4 to 6 weeks, 2 to 6 weeks. I think that's what your book says, 2 to 6 weeks. But again, I like the 4 to 6 weeks because we know that in order to penetrate, to get rid of that Airstream, right, we're going to need a long course of antibiotics, okay, a long course. Did anybody do their clinicals at Promise? Do you guys know what that hospital is? No? Okay, so it's a hospital. More like an LTAC kind of situation in Mesa, okay? It looks a little haunted, not gonna lie, okay? And it was when I first started teaching here, my very first clinical with students, right? Years ago. And I, of course, you know, want to do right. I'm a little bit nervous. And I am walking around checking on the students, and this guy comes up to me, okay? And he's wearing like normal clothes. And he's like, hey, and you know, I have my white lab coat scrubs on, so I look like I work there, or like, you know, I look like a nurse. And he's like, hey, can I get some oxycodone? And I'm like, I'm sorry, are you talking to me? And he's like, yeah. He's like, don't you work? And I'm like, oh, well, actually, I'm an instructor. And I said, I'm sorry, sir, who are you? Are you a patient here? Because I was like, is this a freaking family member coming up and thinking that this is like some sort of free-for-all for drugs? And so I glance as I'm looking at him, because again, he is wearing, I think he had like pajama bottoms on, but like, you know, like clothes. I mean, people come to the hospital wearing all sorts of things, right? So I was like, oh, he's a family member asking for oxycodone. Totally normal in this haunted hospital, right? So I looked and I see a pic kind of peeking out through his shirt. And then I was like, oh my gosh, I'm so sorry, sir. Are you a patient here? And he's like, yeah, I'm, you know, kind of cranky. And he's like, I'm in 508 down the way. And I was like, oh, okay, I'm so sorry. Let me find out what your nurse is, or, you know, we can get you some pain meds. Why do you need pain meds? Not sure, okay, not sure. But again, I was like, who's this guy? And why is he here in this hospital, right? He is like our patient, okay? He is like our patient who is 35, IV drug abuser, right? And he has endocarditis. Do you think that that type of person should be discharged home with a PIC?
No.
Absolutely not, okay? So this guy, I mean, I'm really glad that he was still there because I'm sure he probably wanted to, you know, go AMA. But again, we have to be assessing the type of patient, right? We have to be assessing, is this person capable of going home and finishing, not only finishing the regimen of antibiotics, right? Or do they need to go to some place like an LTAC or a SNF, that way they can get the proper care and they can have their PIC line, right? Because again, 4 to 8 weeks, 2 to 8 weeks, whatever it's going to take is a long time, right? They need longer access. They can't have the forearm that they came in with, right? The peripheral IV. They need like a PIC, right? And you're not going to want to send that IV drug abuser out onto the street for easy access, right? That'd be a terrible idea, okay? So make sure that we're assessing that. We're assessing that when we can think about the treatment. The treatment, we talked about it. The antibiotic is going to be specific to the organism, right? Okay, and then what other nursing interventions do you think you can expect? Let's see, what do we have here? Antibiotics, I love it. Do not stop antibiotics, right? That's the key. right? My family is like notorious for that, where they're like, I'm feeling better, I'm just gonna stop it and save it. And I was like, no. Okay, you must finish the course, right? This is how we have antibiotic resistant organisms out there. It's not good, okay? So they absolutely need to finish, okay? So, okay, we don't really have that. Okay, so teaching dental procedures, absolutely. So in nursing interventions, so let's go back to the guy that we have, right? 35-year-old, just got admitted. We are on the very beginning of treatment, okay? We're trying to figure out what kind of organism he has. We anticipate that he's gonna need a PIC, right? But he's still having symptoms, okay? So one of the main things that he was kind of battling was him being febrile, right? So what kinds of nursing interventions can you anticipate doing for this patient? Acetaminophen? Okay. Do you think acetaminophen is going to break this fever? Probably not. Okay, but we should still try, right? We should be monitoring it. We should be giving acetaminophen. We probably should also be giving some Tylenol, right? And then maybe some other cooling measures. Like what? What do you think? Cold compress, okay. What else? The mom just got here and she is 80 and she's like, it is freezing in this room. And she goes over and hikes up the heater. And you walk in, you're like, wow, it's like a sauna in here. Do you think that's gonna help his fever? No, so cool room, right? As cool as your hospital in Phoenix can make it. What about maybe some fans, right? Because this is what's gonna be plaguing him, you guys. This is what he's gonna be complaining of, okay? This is what he's going to be complaining of. Oh, I'm so hot, but I'm sweaty. And I'm shivering, and I can't get comfortable. Oh my gosh, right? He's gonna be tachycardic, his respirators are gonna be elevated. He might even be desatting a little bit because of the fever. You won't have any sort of resolution from those vital signs until you make some progress with that fever, okay? How often do you wanna check his temperature?
46 hours.
Every hour? Every hour? I love it, absolutely. I totally think that. You're already doing vitals Q1, right? You wanna make sure it's going in the right direction. You don't wanna go in his room 4 or 6 hours later and see that it's 42 or 43. And now he's seizing because he's so incredibly hot, right? We need to make sure that you are, again, thinking about doing an intervention and making an evaluation. Okay, what is the point of doing things, guys, if we're not going to check to see if it works, right? What's the point? So if you're giving someone acetaminophen, giving someone ibuprofen, and you're trying to get this fever down, we should be reassessing, right? We should be evaluating, hey, did whatever I do work? Okay? Now, in thinking about the vegetations, right? Thinking about that it's in the valves in your heart, and you have turbulent blood flow going through your heart. Turbulent blood flow going through it. What kinds of things do you think that he is at risk for? What? Yeah, absolutely. That's huge. We need to be assessing that. Okay? Any sort of abnormality in the heart can impact cardiac output. Okay? Now, again, we know what our cardiac output, what is it called? Formula is, right? Which is what? Heart rate times stroke volume. So we already have an elevated heart rate, right? We have already an elevated heart rate. So we can see if he's tapping out in the 120s, 130s, there's a lot of turbulence going on in there, right? And so that absolutely, any sort of valve disruption can lead to heart failure. We need to be looking for that, okay? Now, to assess that, what kinds of things do you want to assess? How can you know someone's going into heart failure? What?
Is fluid volume?
Okay, so fluid volume, what do you mean?
Like, is he, are his lungs wet? Is he?
So he's
nervous?
overloaded?
Yeah.
I love it, yeah, absolutely. So you just did two different sides. Left side, okay? Left side would be pulmonary edema, right? So when you auscultate, what are you listening for? Crackles, excellent, okay. And then you mentioned edema. What side of the heart would be that? Right side, okay, peripheral, so peripheral edema, okay. Now, if it's super acute, and you're like, dang, he came in for an infective endocarditis, he has crackles now, Things aren't looking good for him. What do you think is going to happen to the rest of his organs? If we have cardiac output issues, right?
Having low output.
Okay, so low urine output, absolutely. Do you think his skin is gonna be looking stellar? Like he can go run a marathon? Absolutely not. He's gonna be clammy, he's gonna be pale, his capillary flow is gonna be increased, okay? So again, I love it. Heart failure, huge complication, okay?
How do you know you're not going through withdrawals?
Ooh, that's a question, my friend. Absolutely, you gotta be on the lookout for that, right? So that could be it, absolutely. If you do all the cooling measures and you're still not making any progress, and then he's like, yeah, I do drink a lot, I dabble in with the meth, that kind of a thing, absolutely. You could need to treat him with other drugs, absolutely, to help bring those vital signs down. So specifically in talking about the vegetations in the heart, right? Now let's think about the turbulent flow of the blood flow going through the heart, right? And pieces fall, la la la, like a crumb to a muffin, okay? Clots, excellent. So if you have a vegetation on your mitral valve, for example, where are those clots gonna go? Okay, so quick review, right? Okay, excellent. So it could go anywhere in the body, okay? Now it depends on what it's causing, right? So if it's regurgitation and blood's going backwards, where is it going? Where is its mitral valve, where is it going backwards into? The lungs. So we could have thrown a clot to the lungs. What's that called? A PE. Okay, so you need to be assessing this kind of complication. Depending on where the vegetations are on the valves, right, we need to be assessing. So what kinds of signs and symptoms are associated with a PE?
Dyspnea,
Shortness of breath, what else? Chest pain, okay, what else?
Overwhelming sense of doom.
Okay, perfect, yeah, they're gonna code, so that's terrible, yes, absolutely. Chest pain, maybe hemoptysis, right, shortness of breath. Okay, so again, we need to be on the lookout for that. What about if it goes to the brain? Stroke. What kinds of symptoms would that be? LOC, so change, confusion, what else? Hemiparesis, okay, excellent, what else?
Difficulty with.
Okay, excellent, increased ICP, I love it, you're going, go big or go home, I like that, okay, what else?
Visual changes, speech changes.
Perfect, so fast, right? Face, is their face symmetrical, right? What else? Speech, okay? Are they slurred words? Do they have aphasia? Okay, you have them hold up their arms to test symmetry, right? So all the things back in the day when you learned about strokes, you had to do the NIST scale, all that stuff. These people are at risk for that. Wow, that sounds like a lot, Professor Bloor. They're at risk for PEs, they're at risk for strokes, okay? Now what about if they have stuff go out into the body, right? They go out into the body, what are we worried about? DVTs, depending on if it goes into the venous circulation, but what about if it's in the arterial circulation and they send it to the left leg? Uh-oh, you go in and you're like, sir, when did you lose a pulse in your left leg? Oh my gosh, it's cold. What happened? Okay, so you can throw clots distally, right? Obviously, hopefully this person would be like, wow, my leg is really hurting, and that would alert you to something that's wrong, okay? But you don't want to get beyond that, right? You don't want to lose a pulse, right? You don't want it to be cold, you don't want it to be pale, because you want to be proactive and be assessing those things, okay? Well, Professor Bloor, I thought we were just talking about the heart. Now you're talking about the full body? You better believe it, okay? You're doing these full assessments to be on the lookout for these complications. It happens all the time, okay? It happens all the time. Even a little, I've seen it where fingers and toes. He threw a showers of clots, and they went to his fingers and toes, and some of them are black now. Because we've occluded that perfusion and cut it off, okay? In that moment, there's not much we can do because the showering has already happened, okay? But what do you think maybe we should do to help maybe prevent it from becoming worse? What kind of drug do you think you should be on?
Heparin.
Heparin. So an anticoagulant, okay, to help try to prevent this. It's not gonna break up those vegetations, I guarantee that, but at least can help the blood be a little bit thinner so that clot doesn't get bigger and include more things, okay? Questions about this? No? Okay. So we talked about assessments and what things people are at risk for. We talked about a long-term antibiotic course, right? We talked about monitoring temperature. We talked about if they go in the future, if they go to the dentist at all, they have a history of endocarditis, they must every single time have prophylactic antibiotics. You absolutely need to be sharing that telling them to share it with their dentist. That way, because any time that they go in and do things, dental procedures in their mouth, they're at risk for getting more vegetations, and who wants that, okay? So we talked about antibiotics. Now, what if the patient proceeded to heart failure? What do we think we're gonna do? What do you think? If they did have heart failure, what do we do? Do you just give them antibiotics for 4 to 8 weeks and hope for the best? What?
Give it a treat for heart failure.
Okay, treat the heart failure. Okay, so what's the cause of the heart failure? Endocarditis, okay. So we're working on it, right? We're working on the antibiotics, but again, remember the air streams. You guys, it's impenetrable. It takes 100 years for us to be able to get through that. Not really, I mean, exactly. But do you think maybe we could do something invasive there? Surgery, yes. Some of these people are going to have surgery, absolutely. They're going to have a surgical, sometimes debridement, where they go in and they get rid of some of that vegetation, okay? Sometimes they replace the valve to get rid of it, okay? So it just kind of depends on the situation and the severity of it, okay? Questions about this? No? You guys good? What's up? It worked 5 seconds ago. Alright, it's fine, it's fine. We're adaptable, we get through, we just gotta get through. Okay, let's do this question. Oh, okay, it was frozen, Sorry. This is a good question. I like this question. Maybe 30 seconds, yeah? You guys are like, Professor Blur, she has all that trickery. No trickery. Things are pretty straightforward, don't worry. Okay, let's talk about this. So, a patient being treated for infective endocarditis is complaining of very sharp, radiating abdominal pain that goes to the left shoulder and back. That's weird. As a nurse familiar with complications of infective endocarditis, what do you suspect is the cause of this finding? Okay, so we know, right, that when people have infective endocarditis, they are at risk for emboli events, right, where they shoot clots everywhere, okay? And so here, let's play the game of elimination because that's the most fun, okay? So right away, we have pulmonary embolic event, okay? Pulmonary embolic event. Now we just talked about this, right? For a PE, what kinds of signs and symptoms is the patient going to have? Shortness of breath. Chest pain, right? Maybe some hemoptysis, okay? It's, again, is that patient having that? They're having very sharp radiating pain that goes to the left shoulder and back, okay? So right away, no PE, okay? What about central nervous system embolic event? So we just talked about that, right? Is any of those symptoms indicative of a stroke?
No.
Absolutely not. No confusion, no facial droop, no speech issues, right? Okay, no, what is it called? Weakness on one side, okay? So we can say, okay, B and C out. So you guys probably narrowed it down, right? The name of the game is narrowing it down. We have the renal embolic event and the splenic embolic event, okay? So who thought it was renal? I know, nobody's gonna say it's okay, you don't have to stay. I was just curious, we're gonna be like, so renal, we know that with renal, you're going to have more flank pain, okay? You're not going to have this radiating abdominal pain to the left shoulder and back. That's called Kerr sign. That is associated with your spleen, okay? So if you wanted more information, okay, if I was here and you're like, Professor Blair, I need more information. What labs might you be able to get to be able to determine if it's a renal embolic event versus a splenic embolic event?
All the renal numbers.
Okay, when you say renal numbers, what are they?
GFR, BUN,
Okay. What's that one other one besides the BUN and GFR? Creatinine. Okay. So again, excellent. I love it. So you're going to get those labs to be able to say, because if you throw a clot to the kidney, they will have elevated levels. Okay. Now, output-wise, do you think that that kidney is going to be working awesome, where the output's going to be stellar? Absolutely not. Okay. So again, rule it out. The answer is the splenic embolic event. Okay. You can see this. They can throw clots everywhere, every which way. Okay. So D is the answer. Perfect. Let's do this one. Oh, select all of the flag. How fun.
Yeah, that's fine.
What was the pain? What type of pain called again?
Kerr sign. I think it's K-E-H-R-S. As infections go, infective endocarditis is probably one of the worst ones to get. You don't want it. You guys ready? Still mulling it over? Maybe 30 seconds?
Splenomegaly, enlarged spleen.
I do like this room because there's lots of room for activities. Lots of room for me to get my steps. I like it. Less claustrophobic, right? Everybody feels that? It's better. I do wish there was a whiteboard in here. I'm going to figure out how to make these whiteboards by the end of today. Yes?
We're just supposed to have people come today?
We are. I know, more room. Less awkward. I know.
Oh, wait.
I was hoping that because of our awkwardness of 129, they'd be in and out. But this does not bode well for us, okay? Because look at, there's 3 tables that they can sit. My guess is that they're gonna sit right here. So then I'm gonna have to like back up. Because I don't wanna like spit on them, okay? Because that, we probably get bad marks for that. Okay, so let's talk about this. So, typical signs and symptoms, right? Symptomology is so important, okay? So important. So do we think that they're gonna have hyperthermia?
Yeah.
Absolutely, right? That's one of the signs, okay? They have a gnarly infection, you guys, a gnarly infection. One of the cardinal signs of infection is the fever, okay? And they're gonna have the fever for a while, okay? For a while. They may not have that 41 degrees Celsius fever, but they are going to have maybe a 38, 38.5. They're definitely not gonna be normothermic, okay? Do you think that they're gonna have an S4 gallop? Professor Bloor, you said that there's gonna have to be weird heart sounds, okay? What is an S4 gallop associated with normally? Anybody know? Aortic stenosis, okay? S4 gallop is usually associated with aortic stenosis. So down the road, if they develop aortic stenosis due to the fact that they had infective endocarditis, specifically on their aortic valve, sure. But we're talking about right now, infective endocarditis, they were just diagnosed. Or we're still trying to figure out what it is, okay? So it's not S4 gallop. C is enlarged spleen, absolutely. Anytime you have any sort of infection, one can get an enlarged spleen, okay? Especially if they're throwing clots everywhere. Hyperkalemia, okay? Hyperkalemia, elevated K, no, not necessarily, okay? Substernal pain that radiates to the back. Interesting. What does that kind of pain sound like? If you had to
Pancreatitis,
throw out,
the pancreas.
what is it?
The pancreas.
Maybe.
It's
So
a little lower.
substernal, so like substernal, right? Radiates to the back. What else kind of pain do you think that was associated? Yes, an MI. Absolutely, okay? So today we are going to dive into chest pain, all the types of chest pain, okay? Substernal pain that radiates to the back is absolutely associated with an MI, okay? Absolutely. So if I suspected an MI, right? What's one lab really quick, down and dirty, that I can send to rule it out? Excellent, troponin, good job. Okay, continuing. F, we have heart failure. Okay, you guys nailed it on the head. Huge complication of infective endocarditis. Huge complication, absolutely. Okay, and then cardiac murmur. Cardiac murmur, right? That's a significant heart murmur you sound. You're like, uh-oh, you need to be thinking infective endocarditis. Okay. Now, in the past, people have been a little upset with me. They're like, Professor Bloor, you just said that heart failure is a complication. Okay, you just said it was a complication and not necessarily a sign or symptom. It can be both, okay? It can be both. It depends on how acute it is, okay? It depends on how acute it is. Because if you have infective endocarditis and you have a gnarly one on your mitral valve and it's causing gnarly mitral valve regurgitation, right? You can have the patient present and already be in heart failure, okay? Does that make sense? So it can take a while, okay? It depends on the severity of those vegetations, the severity of the heart, how impacted it is, or it can be in the very acute phase. Again, what you guys, because you're detectives, you're able to sift through that and understand that if it is in that acute phase, then it will be showing the patient will have those signs and symptoms of heart failure already, okay? Does that make sense? Okay, good. Questions about this multiple choice? Okay, next one. We'll finish up with these questions and then we'll take a break before we get to the next one. And I'm going to work on how to get these up and going so I have a whiteboard.
They're saying yes.
patient being treated for endocarditis? Which statement by the patient demonstrates they understood your teaching about this condition? Okay, so I will stop taking the antibiotics once my fever is gone in order to prevent antibiotic resistance. Do we love that statement? True or false? 1,000,000% false, right? You absolutely do not start just willy-nilly stop taking your antibiotics because your fever is great. We're glad your fever is better, but you must take the full course of antibiotics, okay? I will only wash my hands with soap and water. So weird, right? Like why would, so Purell's totally out, right? You never have hand sanitizer, okay? So again, be careful of these qualifiers, right? I will only wash my hands with soap and water. Be careful of that, okay? That should clue you in that it's probably not the answer, okay? So no, you can still use hand sanitizer, don't worry, okay? I will inform my dentist about my history of endocarditis prior to any invasive procedures. You better believe it, okay? You absolutely do not want to develop another set of endocarditis, right? So you're telling your dentist, yo, I need all of the prophylactic antibiotics I can get, okay? And then I will avoid eating fish and organ meats. Why in the world? You eat them all. Eat them all, you can do that, okay? All right, let's take a break. It's 10:04, so come back at 10:14. Okay, 10 minutes, go to the bathroom, get yourself oriented to the fun library.